Welcome, my digital pathology trailblazers. How are you today? Welcome to the DigiPath Digest number 27. Can you imagine we have done already 27 of these episodes? And several of you have been here several times. It's going to be short and sweet because we only have 4 abstracts that I wanted to go through. Let's start with the first one, which is immunohistochemistry guided segmentation of benign epithelial cells, in situ lesions, and invasive epithelial cells in breast cancer slides. And the authors are from Trondheim, Norway. And I liked this abstract because they did this immunohistochemistry guided segmentation. And I always give this example when they were doing the chameleon challenge. There is this chameleon challenge. It was to detect breast cancer cancer metastasis in lymph nodes. And their ground truth, it was a double ground truth because they had immunohistochemistry. So in the chameleon challenge, they had the immunohistochemistry to cytokeratin to stain the epithelial cells. And they also had pathologists annotate that. And that's a similar framework in this paper. Let's see what they exactly did and how it worked. Obviously, at the beginning, we know that digital pathology is fantastic, right? And it enables segmentation with AI-based image analysis. And it could improve diagnostic efficiency and find associations between morphological features and clinical outcomes. That's our holy grail. And they did develop a model like this, segmentation model for breast cancer, and they wanted to identify invasive epithelial cells and separate these from benign epithelial cells and also in situ lesions. That was the importance. It was important to have all the epithelial cells and then divide them into subcategories. So they had this unit for segmentation of epithelial cells in H&E, and they generated epithelial ground truths by immunohistochemistry. So they restained H&E sections with cytokeratin. So they had the same sections, which is super cool because then you don't have to guess, is it the same cell or not? You have a little bit of architectural distortion of the slide when you stain and restain. It doesn't exactly look the same because of the process it goes through, but it's close enough. Better even than serial sections. Better than serial sections. And then combined it with pathologist annotations. And they had tissue microarrays. So this is important. Tissue microarrays are these slides with little circles on it. And these are there are special machines where you can cut out of histopathology blocks, out of paraffin blocks, these holes. And these are tissue microarrays. So they had these from 839 patients. And they also had whole slide images from 2 patients. It's so cool that whole slide images are just from 2 patients. Okay, and they used to train this model, right? So the sections were derived from 4 breast cancer cohorts. So that's important because they didn't do one cohort. They had different ones to ensure generalizability. And there were tissue microarrays from the 5th cohort of 21 patients, and this was used as a second test set. And they had DICE scores of over 0.7, one even 0.79. They achieved these for invasive epithelial cells, benign epithelial cells, and in situ lesions, respectively. And then what else they did, get rid of this a little bit because it's too much. You cannot see. In addition, what they did in addition, and they also used this qualitative scoring by the pathologist. So this scoring was 0 to 5, and the best results were reached for epithelial and invasive epithelium with scores 4.7 and 4.4 respectively. And benign epithelium and in situ lesions were a little less, 3.7 and 2 for in situ lesions. So they were not happy with that. So they proposed model segmented epithelial cells well, but further work is needed for this subclassification into benign in situ and invasive cells. Am I surprised? Not really. I'm not surprised by that, because if it's challenging, it's challenging for the AI as well. And a topic I feel strongly about, and you've heard about this if you've listened to me, is that when we have to quantify visually stuff that a computer could quantify a little better. And one of these things that need to be quantified for different cancers is that tumor infiltrating lymphocytes. Move my camera a little bit. Tumor infiltrating lymphocytes. And these tumor infiltrating lymphocytes, this time, were checked or were investigated in esophageal cancer. This is a group from China, published in Cancer Medicine. And what they did was these TILs have been proven to be important prognostic factors for various tumors, but it has not been checked for esophageal squamous cell carcinoma yet. ESCC was not checked. This is what they wanted to check, if this be a good prognostic marker. They enrolled retrospectively 626 pathologically confirmed esophageal cancer patients from 2 research centers, and they used their whole slide images and clinical information, and they developed a deep learning method to segment these lymphocytes. And where did they segment? Here we're in the area, in the realm of immune oncology, of our immune cells, immune system trying to protect us, defend us from cancer. And, excuse me. No, I thought I sneezed, but it happened sooner or later. And that's what they wanted to check, if these TILs, tumor infiltrating lymphocytes, are a good prognostic marker. And they checked them in the tumor margin. They designed a model to identify tumor margin. Why tumor margin? Because it's important where these TILs, immune cells, go into the tumor, and then based on the distance from the tumor margin, you decide whether it's a good marker or a bad marker, or you decide your thresholds and distances. It's a little bit of spatial biology, immuno-oncology, this kind of stuff. They divided tissue into intratumor, peritumoral, and stromal region based on the distance from the tumor margins. Let me just show you what they do. My little drawing is going to be, okay, I don't know, let's say this is the esophagus. This is going to be the tumor. And can I change my color? Yes. This is going to be the invasive margin, exactly next to the tumor. And then you're going to have intratumoral and peritumoral, and there is going to be a distance within this invasive margin. Let me know if this makes sense to you. This is the tumor. This is the tumor. I have a better one in my resources. This is our tumor. Anyway, let me know if that was good enough. So they counted TILs in each of these regions. And then they did their statistics and found different cutoff values. And then they also mitigated the selection bias with propensity score matching and analysis. And what were the results? They classified patients based on the cell counts and cutoff values of the TILs, and they have iTILs, tumor infiltrating lymphocytes, the intratumoral TILs, and peritumoral infiltrating lymphocytes, PTILs. So the ones that went inside and the ones that stayed outside. And patients with high intratumorals and peritumoral were defined as those whose counts of both exceeded their cutoff. So they decide on the cutoff, and then they decide, okay, which one is high, which one is low based on the cutoff. And patients with high showed better overall survival and recurrence-free survival. So these are the metrics that they check, okay, is something prognostic or not? And then patients with low intratumoral and peritumoral TILs, and after the propensity score matching analysis. So they discovered, they stated that these TILs are an independent prognostic factor. Their conclusion is that the quantitative distribution of TILs in esophageal cancer patients will help, with the help of deep learning, and serves as an independent prognostic factor for these patients. Then they, of course, want to do further work to decide if you can, to check if you can divide these lymphocytes into subgroups and get more granular spatial information and to improve the predictive efficacy of TILs. This is something that's happening in breast cancer as well, in the whole field of immuno-oncology. Often you use different markers. We're going to have another abstract at the end, the classic of immuno-oncology, Immunoscore. Who's heard of Immunoscore? We're going to move to the next one. And I like the next one because the next one is the title is Effect of Liver Biopsy Size on MASLD Fibrosis Assessment by Second-Hand Harmonic Generation 2-Photon Excitation Fluorescence Microscopy. It's a mouthful, but the important thing about this is that this is label free. It's like you image the tissue directly without processing and without immunofluorescent dyes, right? Without anything. This is a group from UK, Edinburgh, London, but also Bethesda and Richmond, Virginia. And whoever read on this topic knows that fibrosis in metabolic dysfunction, so this is MASLD, is a metabolic dysfunction associated steatotic liver disease. So it's the I don't know if they don't call it non-alcoholic. Here is some NASH. This is caused or this is associated with metabolic dysfunction, not with alcohol that causes fibrosis as well. So basically, liver damage expresses itself if it's severe with fibrosis. And this is a prognostic indicator and clinical trial efficacy endpoint. So you're going to check if there's less fibrosis and then the drug. This SHGTPF, which is the second harmonic 2-photon excitation fluorescence microscopy, images unstained tissue sections. It uses fluorescence, but it images unstained sections. This is super cool because you don't have to stain, right? You know that staining and generating H&E images takes several hours, 8 hours, I don't know. I remember that we had to, in my residency, we had to switch on all the machines for staining, and whenever somebody forgot it and would come during the night because they remembered that they forgot to switch it on, then the whole operations would be delayed for a few hours. We can skip that because we can image unstained sections. But let's get to the meat of this abstract. When integrated with artificial intelligence models, they can generate continuous fibrosis value, Q fibrosis, and ordinal Q fibrosis stage. What they wanted to check here is the impact and is the biopsy size and location. Is it important for accuracy of this thing, right? Of the imaging and of this diagnostic method. They took one unstained section from 100 hepatectomy or explant MASLD cases, and 20 of each pathologist assigned non-alcoholic steatotic clinical research network, fibrosis stage. Okay, so here we have fibrosis stage 0-4. They took 20 of each stage. They used them to create virtual core biopsies by cropping regions from within the whole parent section. They have a whole section and they want to make biopsies out of it. And they make them in with different sizes, but obviously the sizes that would correspond to the size of this biopsy in real life. But they had varied length, 5 to 30 millimeters, with a fixed width, 0.9 millimeters, and fixed length, 15 millimeters. It's funny, the regions varied in length with a fixed length or position within the whole parent section, right? And then the microscopy was used, and Q fibrosis continuous value and stage of the virtual core biopsies were determined. And what were the results, my friends? What did they say? They say that this Q-fibrosis, their AI-based score, correlated strongly with pathologist assigned stage. These specimen already had an assigned stage, and they checked if this Q-fibrosis correlates with that, and that was very high correlation. Then increasing the length and width increased the correlation between Q fibrosis and a continuous value and the agreement with Q fibrosis stage, stabilizing between 20 to 26 millimeter in length and 0.9 in width. So to a certain extent, when the size was bigger, the correlation was better. But then after, you don't have to go bigger than that, because then it doesn't make any difference anymore. Conclusion: longer, over 20 millimeter, and wider, 9 millimeter, 0.9 millimeter biopsies provide more accurate fibrosis assessment using the SHGTPF, and biopsy position and orientation do not influence accuracy. This is here logical outcome, because you have the liver that is affected homogeneously. This fibrosis is not be just in one place and it's not be in the other place, because it's a reflection of the liver function. It's not tumor. You have tumor in one place and the rest is be free. So if you take a biopsy here, you don't biopsy your tumor. Whereas if you take your biopsy here, this is my biopsy needle, then you will have tumor, and then tumor heterogeneity is a lot more pronounced than the heterogeneity of the fibrosis in the liver. It should be distributed homogeneously. So I would also not anticipate that biopsy position and orientation will influence, but you have to check that, because if it's your diagnostic modality, you have to account for all these things. And what they suggest is that clinical trials should incorporate suitable protocols to verify biopsy size that optimize digital fibrosis assessment using our two-photon excitation fluorescent microscopy. This one, because it's a glass-free, I don't know I assume it's glass-free, basically stain-free and processing-free way of imaging. And last but not least, let's talk about Immunoscore. How I am familiar with this Immunoscore, other than obviously reading about it in the literature, when I started my digital pathology career at a digital pathology company, what we were trying to do is to develop an algorithm to quantify immune. No, they actually did it before I even joined. So they worked with the original group that invented the Immunoscore with Jérôme Gallon. We're making a quantitation of the markers that come into the Immunoscore. Of course, I'm going to give you the chance to check the store if you're interested in the earrings. Let me show you the earrings before we finish. So I have my multinucleated giant cells today. We have 3 designs: multinucleated giant cells, cartilage, and Alcyon blue with colon stained with Alcyon blue, that is like white and blue. So if you're interested in getting them for yourself or for somebody else, check this QR code that I have in the top left corner, at least looking from my perspective. And let's do that as I talk to you about the Immunoscore, redefining the landscape of colorectal cancer and colorectal cancer control and care. So the Immunoscore, introduced by Jérôme Gallon in the early 2000s, evaluates immune cell densities, keyword densities, within tumors, offering a more accurate prediction of clinical outcomes in colorectal cancer compared to the tumor node metastasis, the normal tumor node metastasis system. And so we have the Immunoscore that is a better predictor than the normal system that pathologists were using, and it enhances the prediction of recurrence, disease-free survival, and overall survival in early stage colorectal cancer, and identifying high-risk patients and optimizing treatment decisions. So this Immunoscore serves as a prognostic tool with high predictive value in guiding immunotherapy, especially immune checkpoint inhibitors. So one of the famous one is going to be PD-L1 and all these checkpoint inhibitors that are supposed to make our immune system actually fight the cancer, mobilize. That's immuno-oncology, our immune system fighting the cancer, and the drugs are trying to enhance that. So high immunoscore score correlates with better response rates to immune checkpoint inhibitor therapy. And then in addition to colorectal cancer, it has demonstrated utility across various cancers, predicting treatment responses and survival outcomes. The original one is colorectal cancer. There are other cancers where they check this. It has demonstrated utility. The limitation is that it is an image analysis based thing. If you don't have digital slides, then you will be limited in your ability to evaluate immunoscore, and limitations with traditional tumor infiltrating lymphocyte assessments. You have the traditional one where you can stain them with IHC, but also often without even staining. This one is specifically stained for CD3 and CD8, and then you calculate the ratios of these to each other and in specific places in the invasive margin, and similar to what we said with the esophageal cancer. The immunoscore application in guiding adjuvant chemotherapy is constrained by cost and limited data. What they suggest is to advance this with combining it with other markers, P21 and P16, that are markers for assessing cancer malignancy, as well as integrating artificial intelligence and digital pathology. But this score is based on classical computer vision way of assessing these lymphocytes, but you can totally replicate it with image analysis, with AI-powered image analysis. Yeah, they say it's good, but it could be better, and it has limitations compared to normal TILs, tumor-infiltrating lymphocyte scoring. But they say it represents a significant advancement in oncology. This was actually our last one for today. If you are new to this show, new to me, I'm Alexandra Żuraw. I'm a veterinary pathologist passionate about digital pathology and helping you understand it. And I also help you understand it with this book. If you're new, get the book, because you're going to have all the basics there. And there's an AI chapter that's going to be updated in the new edition. And everybody who has the old edition, so this is the physical book that you can get on Amazon, and this is a paid thing. But the one from the QR code is free. It's PDF. So you can totally get the PDF of this book, start your digital pathology journey. And whenever I have the next edition, you're already going to be on my list, and you're going to get the book, the new version of the book, the PDF of the new version. And there's going to be a new version on Amazon. If the earrings are something interesting for you, and also in this store, you can find other courses that we have, a course about AI and about image analysis in pathology. If that's something of interest to you, go ahead, check the QR codes, and I talk to you in the next episode. Thank you so much for joining me.